Hepatitis E is a calcivirus, like non-enveloped RNA virus. It's single-stranded RNA and about 32 to 34 nanometers in diameter. So to contrast it to hepatitis A, it's very liable, meaning it does not survive well outside of the host and is more easily destroyed by environmental factors. Up until recently, it could not be cultured in a lab, which made it difficult to study. Like Hep A, it is transmitted fecal orally, but the clinical significance differs, especially in pregnant individuals. The incubation period for this virus is about 40 days, and most people will recover without chronic infection. However, illness severity increases with age, similar to hepatitis A. So, the critical high yield point is the case fatality rate in pregnant women jumps 15 to 25% compared to the normal rate, which is 1 to 3% overall. We don't quite fully understand the mechanism, but we know that there's a hormonal and immune changes during pregnancy that exist, and we believe that they can worsen viral replication and worsen hepatic oxidative stress. So the graph mirrors the timeline of infection. We see that hepatitis E virus will show up early in the stool, similar to Hep A. Our IgM anti-HEV rises during acute infection, and this is the diagnostic marker of recent infection or exposure. IgG anti-HEV appears later and will remain positive after recovery. Um, this indicates past infection as well as immunity. Our ALT levels, kind of right here in the center, will rise and fall with hepatocellular injury, and they gradually do return to baseline as the immune system clears the virus. Most hepatitis E outbreaks occur in developing regions where drinking water sources are contaminated by sewage. There have been large endemics in multiple different countries, some of note India, China, Africa, Mexico, even parts of Russia, USSR, and in the US and other non-endemic regions. Hepatitis E cases are rare and usually linked to travel. And the prevalence of anti-hepatitis E antibodies in the US is low, under 2%, and transmission between people is very minimal. Hepatitis E is prevented, not treated, and so travelers to endemic regions should avoid drinking water or beverages with ice from unknown sources, avoid raw shellfish, and avoid uncooked fruits and vegetables unless they peel them themselves. Immunoglobulins from Western donors do not protect against hepatitis E, and although Ig from endemic regions could contain antibodies, its effectiveness remains kind of unclear. Unlike Hep A and B, there is no widely available Hep E vaccine in the US. So overall, Hep E is an RNA virus transmitted by contaminated water. It causes acute hepatitis, never becomes chronic. The key risk group is pregnancy, and those people face a dramatically increased mortality rate. Therefore, prevention focuses on avoiding contaminated food and water in endemic areas. So this is a good transition kind of into our final review for hepatitis. So when comparing these viruses, this is kind of a blurry slide, but A and E is fecal oral, never chronic. B, C, D is bloodborne, can be chronic. D needs B to replicate, and understanding which markers to order, IgM, IgG, HbA, HBE, AG, viral load, etc., is essential to diagnose and to monitor. In the lab, the focus is on recognizing patterns. So our goals are going to be, is this acute or chronic? Is this patient immune from vaccination or past infection? And you want to pair the clinical scenario with serology. On your exams and in clinic, you will always return to the logic of the serologic markers. So this concludes our kind of discussion on viral hepatitis. Understanding these markers will help you diagnose, stage, and manage hepatitis confidently in clinical practice.